Two patients, one valve, and completely different exam stems. The first stem points toward classic aortic stenosis findings. The second stem points toward classic aortic regurgitation findings. Stem 1, 72-year-old man with exertional syncope. He has a harsh crescendo-decrescendo murmur at the right upper sternal border. The slow carotid upstroke and diminished S2 complete the pattern. Stem 2, 34-year-old intravenous drug user. He has widened pulse pressure, bounding pulses, and a blowing diastolic murmur. The laterally displaced PMI signals left ventricular enlargement. Here is the single diagram that explains both diseases. Aortic stenosis means the valve will not open normally. That creates an obstruction to forward flow leaving the ventricle. Aortic regurgitation means the valve leaks backward during diastole. These lesions are mirror images in hemodynamic terms. Stenosis produces pressure overload because ejection faces resistance. Regurgitation produces volume overload because blood returns each beat. Everything in both stems follows from that single distinction. Back to stem 1, every finding now gets decoded. In older adults, the usual cause is senile calcific degeneration. In younger patients, a bicuspid valve calcifies earlier. Either way, stiff leaflets obstruct left ventricular outflow. The ventricle must generate much higher pressure to eject. That leads to concentric hypertrophy with thick inward growing walls. Mechanistically, sarcomers are added in parallel, not in series. The chamber stays relatively small while the wall thickens. The classic symptom triad follows directly from this physiology. Angina occurs because oxygen demand exceeds coronary supply during exertion. Syncope occurs when exercise lowers SVR but output cannot rise. Dyspnea reflects diastolic dysfunction from a stiff, hypertrophied ventricle. Now decode the murmur shape and timing. Flow through a narrowed orifice creates turbulent systolic ejection noise. It crescendos, then decrescendos because the pressure gradient rises and falls. That is why the stem says harsh crescendo-decrescendo systolic murmur. Murmur location also follows from anatomy and flow direction. It is loudest at the right upper sternal border. It radiates to the carotids because turbulence travels with blood. The stem is describing the path of high-velocity ejection. Two bedside clues strongly point toward aortic stenosis. A calcified, immobile valve closes weakly, so A2 becomes soft. The carotid pulse is small and delayed, pulsus parvus et tardus. Together, these findings lock in the stenosis diagnosis quickly. Now decode stem 2 using the same mechanism, first approach. In this patient, infective endocarditis prevents proper leaflet coaptation. Other causes include aortic root dilation from Marfan syndrome or syphilis. Whatever the cause, the valve fails to close during diastole. Blood leaks back into the ventricle every diastole. That regurgitant volume adds to normal pulmonary venous return. The ventricle adapts with eccentric hypertrophy and chamber dilation. Sarcomeres are added in series, making the chamber enlarge. A larger ventricle physically shifts the cardiac apex. Normally, the point of maximal impulse stays relatively medial. In chronic regurgitation, dilation pushes the PMI laterally and downward. That stem phrase is simply a bedside clue to eccentric hypertrophy. Pulse pressure becomes the signature hemodynamic clue in regurgitation. Normal pulse pressure is roughly 40 millimeters of mercury. In AR, systolic rises and diastolic falls, widening the gap dramatically. That number is a direct readout of regurgitant physiology. The arterial pulse also reflects this widened pressure swing. A normal pulse rises and falls with moderate amplitude. Regurgitation creates a forceful bounding pulse from massive stroke volume. The pulse feels strong because pressure surges then rapidly drains. Now decode the regurgitation murmur itself. The leak starts after valve closure and continues through diastole. It begins loud because the aorta to LV gradient is initially highest. It decrescendos as ventricular filling gradually reduces that gradient. Location and positioning help you hear aortic regurgitation best. The murmur is best heard along the left sternal border. Leaning forward brings the aortic root closer to the chest wall. High pressure through a small leak makes it blowing and high-pitched. Put the two lesions side by side and compare. AS is systolic, RUSB, concentric, and parvus et tardus. AR is diastolic, LSB, eccentric, with wide pulse pressure. First trap, severe aortic stenosis can sound like mitral regurgitation. High-frequency components may radiate to the apex and mislead you. The giveaway is a soft or absent A2, not mitral disease. If S2 is diminished, stay in aortic stenosis territory. Second trap, compare stenosis with hypertrophic obstructive cardiomyopathy. With Valsalva, the aortic stenosis murmur gets softer. HOCM does the opposite and becomes louder with less preload. That contrast is one of the most tested murmur questions. Third trap, severe regurgitation can mimic mitral stenosis. The regurgitant jet hits the anterior mitral leaflet and vibrates it. That creates a low-pitched apical diastolic rumble. No opening snap and no rheumatic history favor Austin Flint. Final trap, acute and chronic regurgitation present very differently. Acute AR gives no time for ventricular dilation or compensation. Chronic AR allows gradual dilation and years of tolerated overload. So acute AR may have pulmonary edema, shock, and a soft murmur. Let's lock in the 3 highest yield takeaways. First, stenosis means pressure overload, concentric hypertrophy, and soft S2. Second, regurgitation means volume overload, eccentric hypertrophy, and wide pressure. Third, remember the 4 traps that commonly fool test takers. Now you can solve most aortic valve stems in seconds. Use the axis. Won't open means stenosis, won't close means regurgitation. Drop your toughest aortic valve vignette below for a decode. Next week, we tackle DHP versus non-DHP calcium channel blockers.